Welcome to TCNtalks. The goal of our podcast is to provide concise and relevant information for busy hospice and palliative care leaders and staff. We understand your busy schedules and believe that brevity signals respect. And now, here's our host, Chris Comeaux.
Welcome to TCN Talks. This is my favorite time of the month, and Mark, Cohen, and I always do the top news stories of the month, so this is top news stories for February, but we have a special guest who's joining us today, and so Cordt Kassner. Cordt, welcome.
Thank you so much. It's a pleasure to be here.
Well, Cordt, why don't you introduce yourself? What does our audience need to know about you? And I'd love you just take it into about hospice and palliative care today as well.
Sure, happy to. Chris, great to see you. Mark, great to see you as well. And thank you for all the TCN Talks listeners joining today. By way of brief introduction, I've worked in hospice and palliative care over 25 years. First in research at the University of Colorado Anschutz Medical Center with Dr. Gene Kuttner, who is absolutely amazing. Then as CEO of the Colorado State Hospice Organization, and for the past 16 years served as CEO of Hospice Analytics, a quantitative research company I founded, working with hospices and others to use Medicare claims, cost reports, and quality information to improve access to and utilization of high-quality hospice and end-of-life care. Starting January 1 of this year, I also added publisher of Hospice and Palliative Care Today to my list. As you know, Hospice and Palliative Care Today builds on Mark's work with Hospice News Today and is my qualitative research outlet. Something most listeners probably don't know about me professionally is how hard I work to show up and listen. I serve on numerous boards, for example, the Pikes Peak Hospice and Palliative Care Board, which is part of Care Synergy in Colorado. I serve on the Illinois Hospice and Palliative Care Organization Board, the Hospice and Palliative Care Network of Maryland Board, and I'm research staff for the Louisiana and Mississippi Hospice and Palliative Care Organization. Of course, I share research insights with these groups and help however I can, but mostly I try to show up and listen. For example, yesterday I was on a call with Drs. Russ Portnoy and Laura Dingra from MJHS in New York City. We were on a collaborative call with colleagues at Columbia University discussing another potential NIH grant, and Russ mentioned an article about how private equity ownership has impacted anesthesiologist practice groups. Private equity has also impacted the hospice movement the past few years, and so readers will notice today I ran a story in today's newsletter about this anesthesiologist practice group with a note that kind of highlighted the impact of private equity. These are all connections and opportunities to listen and to help hospice leadership connect the dots. Personally, listeners will discover quickly if we're chatting that my wife of 30 years and my son and daughter in their early 20s all love to go hiking and play pickleball. If you're not familiar with pickleball, it is the latest addiction. Moving into hospice and palliative care today, Mark and I have known each other for several years, and I was an early subscriber to Hospice News Today. Like many TC Talks listeners, I used to read Hospice News Today first thing in the morning. I'd typically forward a couple of articles to colleagues every day. When Mark announced his plans to step away from Hospice News Today, while he's still continuing his other communications consulting, I expressed interest in building on his work. Late last year, we agreed to a transition plan between Hospice News Today over to a new company that I incorporated called Hospice and Palliative Care Today. Let me say early and often, I'm so excited to have Dr. Joy Berger as editor-in-chief. Listeners will know Joy as the founder of Composing Life Out of Loss and former CEO of the Association for Death Education and Counseling, or ADEC. Being discreet, I will just say she has a wealth of experience and has worked in hospice and palliative care a little longer than me. So if you don't know Joy, you'll have an opportunity to meet her on a future TCN Talks podcast. We officially began publication on January 1st of 2024. Currently, we have over 1,200 subscribers across 48 states. We've run over 1,100 stories with 225,000 impressions and 60,000 click-throughs on stories. This is an amazing start. As Hospice and Palliative Care Today subscribers know, some things have remained similar to Mark's work. For example, our commitment to provide a thorough environmental scan of all media content relevant to hospice and palliative care professionals. A few weeks ago, I compiled a newsletter and then went back and counted how many articles I eyeballed that I reviewed to select the 20 to 25 articles in the newsletter. I was amazed. I had reviewed about 1,800 articles that day to pick the 22 articles that were in that newsletter. These were from paid subscription services, newspapers, magazines, journals, online resources, TV and film, podcasts, a lot of the same resources that Mark has used. We also try to balance our content. We're being a bit intentional to focus 33 to 40% of our articles specifically focused on hospice and palliative care information. The rest of the newsletter are post-acute care and general healthcare news articles we believe are important for our readers to know about. We've also made a few changes. The biggest change for the readers is that it's now free. We encourage everyone in hospice and palliative care leadership, as well as clinicians and those working with hospice and palliative care providers, to subscribe to receive our daily email newsletters. Our expenses are underwritten by sponsors like Telios, and we try to appreciate and acknowledge our sponsors in several different ways. So, Chris, thank you, and thank you, Telios, for your sponsorship. And if listeners are interested in sponsoring Hospice and Palliative Care Today, I'd love to talk with you about that. Second, we're hosting a webpage. So the website is www.hospicepalliativecaretoday.com. The homepage is today's newsletter every day. So the homepage changes every day. And we've made historical newsletters available on the site, along with several other additional resources. Third, we're able to track, we're able to track who's reading what. And by that, I mean, what are the most read stories by CEOs, or by physicians, or by readers in Florida? We use this information to fine-tune the stories that we select and run. I could say that we're incorporating AI algorithms to improve our content, but I'm old enough to just say we do some computer programming and database management, and that all of that's the same stuff. Finally, we've made some innovations that are planned for later this year. One thing that's coming is individually sorting content for each reader based on the categories of stories read most. So, Chris, if you read more hospice news stories than me, and I read more research stories than you, then our individual daily newsletters will be sorted accordingly. Second, we're also allowing readers to opt in or opt out of content. So, Mark, if you have no interest whatsoever in our general news category, you can opt out of it, and then maybe your daily newsletter has 15 stories while mine has 22. Finally, we're going to be doing some integrating some search engine options to allow subscribers more specific ways to access information. So some very exciting times ahead. In terms of February stats, just to kind of wrap up with this, Mark had kind of talked about the stats on last month's podcast. So in February, we ran 502 stories. 86 of those stories, or 17%, fell into our clinical category. 85 stories, 17%, fell into hospice news. And then 65 stories were in the general news category, 13% of articles. We've got about 20 different tags, 20 different categories that we break stories into, and those were the top three. Interestingly, when we break it out by the kinds of stories that were most read, in February, we had 34,300 click-throughs, meaning we put in 5 sentences or less on a story. Our goal is to, number one, let you know the story exists, and number two, if you're interested in that story, click on it and read the source document. Read the whole thing. Like that, we want to get you to the source story. So we also count those click-throughs. We had 34,300 click-throughs, 10,700 of them, 31%, were on our headline stories, which tells us that we're probably dialing this in identifying appropriate headlines. 10,500 click-throughs, again, 31%, were on hospice provider stories, which is telling us people read the hospice provider stories, so we need to keep that front and center and important. The third category of most clicked through were on the research stories. We had 3,000 click-throughs, which is about 9%. On the research stories, that's a new area. I go in, I review dozens of different journals and do searches to allow the readers to be familiar with the research peer-reviewed journal articles that are out there, because when I talk with people, oftentimes they're not as familiar with that research, and so this is just another opportunity. So with that, I know you both are planning on commenting on individual stories and observations. So Chris, thank you again for letting me join you today, and I look forward to hearing what you have to say.
Well, first off, congratulations, Cordt. I mean, I got to imagine Mark is smiling. I mean, great leaders want people to succeed and do better than them. And obviously, we both honor Mark for the incredible legacy and work he's done. I mean, we wouldn't be here today doing this show. And, Mark and I envisioned this show. Mark and I were working on a couple of projects, and I thought, the importance of leaders knowing what's coming and realizing the unique aspect of what Mark was doing with his newsletter. That's why we did this, to say, okay, hey, C-suite leaders, this is what we hope you didn't miss. But how you've taken it over, Cordt, now how you're applying technology. I think some of our peers are worried of, was artificial intelligence going to eliminate me? And as far as whatever they do in healthcare. But I think this show and you is a good example of, I see how what you're doing is enhancing what Mark and I are going to do. And it's going to help us get even more on point on this show going forward to say, hey, here's what the data shows. Here's what people are clicking on. And here's what we hope you did miss. And here's a little bit of commentary in a couple of those stories. In other words, the technology with really good thought leaders together, you produce a better product. And I think what you've done is a perfect metaphor for that. I mean, Mark is a bit of an artist and really a virtuoso in what he's doing, but then how you've built off of that. So again, just congratulations, and 1,200 subscribers already. That's awesome. Do you have a goal where you'd like to see it by the end of the year, Cordt?
I do. I again, kind of right brain, left brain, and thinking about the number side, but the impact side. I would like to be at 2,500 subscribers by the end of June and 5,000 by the end of the year. So we'll see if we get there. I hope so, and encourage readers to forward links to subscribe to your colleagues and associates who may find it also helpful.
I agree. And I think we should be there because, we're navigating the most difficult times certainly our field has ever seen. And the whole point of why you would want your newsletter on a day-to-day basis, why you want to listen to this podcast, if you're going any journey and if you don't have the intelligence of what you're going to encounter, you're in a pretty a journey that's fraught with a lot of peril. And so we want leaders to navigate, because what it means for patients and families for us to navigate is just, it's amazing and it's important. It's super important. So I believe you're going to get there because people are going to pay it forward. And I know you're going to keep improving with those, just all those enhancements that you were talking about earlier. So again, congratulations, Cordt, both of you. Enjoy.
Thank you.
All right. Well, Mark, you're up, man. What should people have not missed?
Well, thank you, Chris. I appreciate it. And thank you, Cordt, for the preliminary deep dive into the data. Having crunched the numbers for this show, this podcast all last year, it was quite the luxury for me to listen to someone else tackle some of the metrics of hospice coverage. And I do hope that most listeners who were also readers of Hospice News Today when I was editor and who are now 2 months into readership of Cordt's Enjoys Hospice and Palliative Care Today will agree that the transition from one publication to the next has been an exciting one. It's been informative, different, and the publication is still very much incredibly utilitarian. I myself am so pleased to benefit from the great work that Cordt and Joy do each day. One of the interesting aspects of the data crunching that Cordt has done is that we, by tracking clicks on each headline, is that you can look at the most clicked upon stories, but you can also look at those articles that had, in my opinion at least, or somebody else's opinion maybe, those articles that had surprisingly fewer clicks than would have been expected. And I'd actually like to dive into a handful of those articles for the podcast this month. Headline number 1, Riverstone Health closing hospice facility in Billings. This headline had fewer than 10 clicks. In fact, most of the articles in February that dealt with closings and openings received relatively few clicks. It's certainly confusing that seemingly one new hospice inpatient unit is opening just about for everyone that closes these days. But there's no cookie cutter answer as to why those units are closing. As we noted at the end of last year in January on the podcast, when it's a hospital doing the closing, they can do an incredibly poor job of messaging about their decision to the communities that actually help build these units through their philanthropy. So whether a hospice has a unit or not, whether a hospice has a competitor that has a unit, whether a hospice is for-profit or not for-profit, I believe there's something to be learned from every one of these opening and closings articles. And I recommend that readers of Hospice and Palliative Care Today take a minute when there is an article like this to scan the story. Headline number 2, Medicare Advantage profitability on the decline, Moody's finds. Okay, I'm sure I'm not the only reader of Hospice and Palliative Care Today who is really tired of reading about Medicare Advantage and the large, rapacious insurance companies that are running roughshod over the entire payment system. But this article, again, had fewer than 10 clicks last month. Medicare Advantage is a perhaps regrettable fact of life. As a CEO, Chris, you know better than I, and as a Medicare data expert, Cordt, you would know better than I as well. But under the heading of keep your friends close and your enemies closer, I think more folks ought to be diving into stories like this as well. Headline number 3, SSM Health assumes ownership of Visiting Nurse Association of Greater St. Louis. This article from Hospice News also received fewer than 10 clicks last month. I think every M&A article is worth a serious look. And in this case, given the slow decline in the number of VNAs around the country, including VNAs like St. Louis that diversified into hospice care, I think both for-profit and not-for-profits would be interested in knowing more about a transaction like this. Was there an actual sales price? Or did the hospital merely assume liabilities and assets, assuming there were any assets? Is the hospital acquirer guaranteeing all jobs? Or in this time of workforce shortages, might there be a few experienced healthcare workers looking for work, or at least looking to jump ship because of a new employer? How big is the footprint of the acquiring organization, and what post-acute services does it already provide? I think these are all worth knowing, whether you're a hospice in a SSM market or not. Headline number 4, how Steward Health's relationship with private equity soured. We noted Steward's troubles in our podcast last month, Chris, and things have gone from bad to worse for them. What makes it interesting, in my opinion, is that it wasn't that many years ago that Steward was being held up as an admirable example of a mid-size hospital chain owned by private equity that was executing a multi-state roll-up strategy. And what makes this particular modern healthcare story compelling, even though it too had fewer than 10 clicks, is that Steward started out by gobbling up a handful of failing hospitals in eastern Massachusetts. And that today, Massachusetts Senator Elizabeth Warren now is actively going after private equity in all aspects of healthcare. Given the amount of private equity investment in hospice providers and hospice vendors, you'd think more readers of Hospice and Palliative Care Today would have taken a longer look at this, especially since it was published by the leading business authority in healthcare, the trade publication Modern Healthcare. And I'll close with a fifth article, a clinical article, Bristol Hospice's Quest to Patient Sleep. This Hospice News article garnered all of 12 clicks in February. count me surprised. If there are any hospices, local or regional, national, for-profit or not-for-profit, that have a sleep disturbance service offering for hospice patients, they have not gotten any media coverage of it. In my 12 years of publishing Hospice News Today, I can't recall a single article like this. The beauty of Hospice News Today and now Hospice and Palliative Care Today is how easy it makes it for hospice decision makers to find out about new programs like this. When a hospice patient suffers from sleep disturbances, the patient's caregivers suffer too. The fact that this program got a write-up in Hospice News Today is incredibly significant. So those are 5 articles that barely got any attention in Cordt's and Joy's newsletter last month, Chris and Cordt, that I think deserve more attention from readers. I think to some degree folks are probably still getting into a routine with how they read the newsletter, but I hope that folks cast a broader net given the broader offering that Cordt and Joy are providing. And I'd like to close with a reminder that Hospice and Palliative Care Today does operate, as Cordt noted, on a free subscription model. And there is certainly a growing audience of hospice decision makers who are reading the daily newsletter, which accepts limited advertising. So if you're a hospice vendor or if you're a provider looking to grow and expand your family of hospice organizations, you really should think about contacting Cordt to find out more about how to become an advertiser and get in front of those 1,200 and growing readers every day. Back to you, Chris.
Well said, Mark. Well said. Well, now also just thinking the beauty of us doing this podcast, there's so many things. I love the metaphor, setting the table. So writing the article, and Mark, you've done some beautiful master classes, but how you title the article, there's so much in how the table is set probably determines whether people click on it. And so the fact that you're still calling those out to go, hey, I hope you didn't miss these, because with my years of experience, these are some reasons why I would have paid attention to it. So that's a good segue. And one really cool enhancement that we're starting this month, after last month, I reached out to Cordt and he goes, yeah, we can do that with the technology. So I've cited 93 articles. I'm going to try to just hit the high points, but we're going to actually attach that. And then probably next month, we'll have the ones that Mark called out in mine as attachments to the summary with the podcast. Again, all of being service to hospice leaders. The whole point of this is giving you information so you could up your game. And what that means is better serve the mission for the patients and families that your organization serves. So my categories have really gotten finally a fine point on my categories, especially having done this with Mark all of last year. I always want to start with mission moment. So there are a lot of great articles. I won't cite them individually. There are at least 4 about President Jimmy Carter and the fact that now he's been in hospice care for over a year. I remember saying out loud with a couple people, wouldn't it be an amazing blessing if President Carter was at least greater than 6 months? And here he is a year later, which really does change the conversation and moves the perception of, well, hospice means I'm dying tomorrow. And so, again, President Carter, and of course, Mark, your relationship with the Carter family, he has just been a great blessing all the way to the end of his life and even shifting the conversation. A couple other mission moments I want to call out. So Kat Janice, who is 31, it's just a heartbreaking story, but she wrote an amazing song for her son, Dance You Out of My Head. That went viral. And so she just passed away. Actually, I think that technically that's going to be in a March news story, but she just passed away. But there's still some great coverage about her and her journey. Again, shifting the conversation in what I would call a mission moment. Cordt, I thought about you in this one, death and redemption in an American prison. And so I know, Cordt, that's something that you've been passionate about, but what occurs at Louisiana State Penitentiary at Angola. And there was a great KFF news story. In fact, I'm actually going to have one of the key leaders at KFF on TCNtalks a little bit later this year. So I had that one as a mission moment. There was a Wisconsin Public Radio article, How Do You Live While Your Brother is Dying? And a teen's take on hospice. Thought that was a beautiful mission moment. And then this is one that just put it in the mission category because, frankly, I didn't know this, that there's a World Day of the Sick. But incurable isn't uncurable. Pope's February intention for the terminally ill. Pope Francis explains that when some people talk about terminal illness, there are 2 words they often confuse, incurable and uncurable, but they're not the same. So I thought that was a pretty cool mission moment. And kudos to Pope Francis for calling out this great work that we do. So that was my first category. Second category is always reimbursement. So I'll kind of hit these a little bit briefer. But reduce federal share may force state Medicaid programs to cut their services. Another article, healthcare costs associated with hospice use for people with dementia in the U.S. The policymakers in the U.S. are increasingly concerned that greater use of Medicare hospice benefit by people with dementia is driving up costs. So a word of caution from that article. CMS proposes to increase accreditation organization oversight. And so that was a pretty big article that hit my radar screen. We know all the work from Ava Kaufman. There was a Hospice News article by Jim Parker. California Hospice Network, state falls short in curbing the potential malfeasance, even after all the light that Ava has brought to some of the horrific things that occur, especially in the West, but California for sure. And then some bills that came out of that, but still you have this proliferation of hospices. Another article, concurrent Medicare hospice and curative care improves quality and reduces costs by 13%. And they actually cited some of the data from the MCCM. Hospice benefit policy manual update related to the addition of marriage and family therapists or mental health counselors to the hospice interdisciplinary team. And so this is where I love how Cordt's expanding what he's picking up. And so that's one that jumped out at me this month. And then last one under the reimbursement category, hospice fraud back in the spotlight, with new data also raising questions about home health care. That was a hospice, home health care news by Robert Holly. My next category is Medicare Advantage. And as Mark said, in fact, I was going to put a personal note on what Mark said. I have a family member just passed away. As soon as we're finished taping today, I'm heading out for a funeral. Got to drive 8 hours to be with family. This family member had dementia and got signed up for Medicare Advantage, which was not the best option for this person. And so there's a lot of negative press about Medicare Advantage. So I'll just cite some of the titles. Providers urge CMS to use caution in the midst of the hospice VBID implementation. Amen. Private equity Medicare Advantage investment slumps. Aetna forecasts higher Medicare Advantage costs. Medicare Advantage provider benefit cuts are going to follow the rate reductions because Medicare Advantage programs are getting rate reductions. Humana eyes $700 million in cuts amidst over a $541 million loss. Government warns Medicare Advantage insurers not to deny care based upon AI. Couple of damning articles of how they're using AI to automatically, literally within seconds, to actually decline care. CMS seeks input on Medicare Advantage transparency policy. Medicare Advantage plans face new rate cuts. So I'll kind of truncate. I had 3 or 4 more, but it's all the same kind of theme there on Medicare Advantage. Next category is just competition to be aware of. And so a couple of interesting ones I was cited here. So United States buying or selling hospice, there's 36-month rule prohibiting change of ownership now applies. It's now in play. Article, the 10th largest U.S. healthcare companies by revenue. I've been citing that United Healthcare is a $180 billion company. Guess I've been sleeping at the wheel. They're now a $372 billion company. Next behind them is CVS, $357 billion, McKesson at $300 million, Cencora at $272 billion, Cardinal Health at $216 billion, Cigna at $195, Elevance at $170, Centene at $154, HCA $65 billion, and rounding out the top 10, Molina with $34 billion. Had no idea, but just thought that was super interesting. As leaders, we need to know that.
Thank you to our TCN Talks sponsor, Delta Care RX. Delta Care RX is also the title sponsor for our April and November 2024 Leadership Immersion courses. Delta Care RX is primarily known as a national hospice, PBM, and prescription mail order company. Delta Care RX is a premier vendor of TCN and provides not only pharmaceutical care, but also niche software innovations that save their customers time, stress, and money. Thank you, Delta Care RX, for all the great work you do in the end-of-life and serious illness care.
And now some mergers and acquisitions under kind of the category of just competition and mergers and acquisitions. Hospice of Western Reserve plans to merge with Hospice of North Central Ohio. Centrica Care Navigators affiliates with North Star Care Community. and Elevance Health's vision, transforming Louisiana's healthcare through acquisition. There's been an on and off again kind of potential merger with Blue Cross Blue Shield of Louisiana with Elevance. So next category is workforce challenges, and I usually substratify those into three. Number one, articles that paint the picture. Number two, the implications of the workforce shortage. And then number three, the solutions that people are emerging. So here are the ones that paint the picture. C-suites clinicians are burning out at both ends. Interesting, of course, we know about the staffing challenge, but talking about burnout at the C-suite level. And so that was actually in Becker's. How many docs are feeling burnt out? And then the tagline was almost all of them survey finds. That was on MedPage Today. Next, 10 states where nurse burnout is Googled the most. That was a fascinating article in Becker's. And then the employment outlook for hospice aides. That was in Hospice News by Holly Vossel. And then last one in North Carolina, a fascinating report defines healthcare worker shortage and recommends solutions. I downloaded that and now have that whole report on my actual desk. Next subcategory is the implications of the staffing issue. So what 54% of physicians want enough to take a pay cut? And it's really about feeling more purposefulness and just work-life balance, etc. Next is, will home care wage violations spark closures or more workers? ? That was in Modern Healthcare. Minnesota Nurses Union proposes cap on hospital CEO pay. And then last one in the category of implications, highest paying cities for nurses in every state. I'll cite the top five. Number one, California. Number two, Hawaii. Number three, Alaska. Number four, Connecticut. And then number five, New York. Now, the third category is solutions. There were actually a little bit less solutions this month, or at least less solutions that I picked up on, but just a few articles. A KFF article, healthcare workers push for their own confidential mental health treatment. Inside Hackensack Meridian strategy to reduce nursing turnover. This was a really interesting in Becker's. What the 4-day work week could look like in healthcare. Love that article. Can artificial intelligence improve doctor-patient visits and reduce burnout? And then last, how people with disabilities are making a positive impact in the workplace. A population demographic maybe people haven't thought about as a potential workforce solution. All right, this next category, I'm going to just try to be briefer, but it ends up being probably the largest volume of articles I've been citing under, but I call it patient, family, and future customer demographics and trends. And so, Cordt, I think you're really knocking it out in this category, but I'll just cite a few. Funerals are becoming a thing of the past as end-of-life rituals actually change. Article about the state of caregiving. Mark, this is something you've brought the attention to, especially last year, but this was Becker's. 418 rural hospitals, 418 are at the risk of closure. How the funeral industry got the FTC to hide bad actors. That was a Wall Street Journal article. Medicare is booming and providers are bracing themselves. So this was talking about the silver tsunami. Nursing home system faces foreclosure amidst $51 million in unpaid debt. Why I cite that under kind of trends is I'm concerned that is going to be more and more a trend going forward. Are hospice Google ratings correlated with patient experience scores? Evidence from a national hospice study. That was an American Journal of Hospice and Palliative Care. Healthcare bankruptcies in 2023 hit the highest level in the past 5 years. And of course, rural hospitals caught in not only the challenge we were saying earlier, but also the aging facility dilemma. Mark actually had a great thing I'd never heard of before. Mark, what was that act that you cited last month? We talked about it so much.
The Hill-Burton Act.
That's it. And how much, when things happen that far in the rearview mirror history, you don't realize the implications on the economy, but just the billions of dollars that actually built a lot of those rural hospitals and how that went away. And then now you have these aging facilities. Explore the enormous benefits of multi-generational living in this essential guide for the modern healthcare family. I love that as a trend. I think that's going to have to be part of the solution. And then there's just an article about key palliative care trends to watch in 2024. And then coming to terms, female veterans' experience of serious illness. It was a great article and really citing the demographic of a lot of female veterans. All right, so that was my category, demographics and trends. I just had a few. The next few I'll be much briefer. Regulatory and political, there were just a few. How CMS rule can tighten accrediting organizations' oversight. And then Mark, the one about how Stewart Healthcare's relationship with private equity soured. Medicare threatens to pull funding from HCA's embattled Mission Hospital. That's right where I live in Asheville. And then how PBM legislation would transform the industry. Unfortunately, since I cited that article, it actually got pulled out of the actual healthcare bill. So this looming PBM issue that is putting a lot of local pharmacies out of business, it's not being solved in actually what's going forward. And then the last one, Mark, that called out to me, Atrium Health, a unit of local government like no other. And just Mark pointing out, keeping that because Atrium is really being challenged. Are you really a not-for-profit organization? All right, my next category, technology and innovations. Quite a few there, but I'll just cite a few. An attack on the entire sector, the fallout from Change Healthcare hack. As we're becoming more technologically savvy in every aspect of healthcare, you see where we're at risk for cyber attacks. And so as we're doing this taping today on March the 1st, as far as I know, Change Healthcare has still not been implemented. So you've got so many implications. I talked to someone yesterday that works in the oncology sector, and this organization has $200 million of revenue per year of chemotherapy, and they can't bill for anything right now because of the system being down. There are a couple of great articles I put under technology. VR therapy, more than 50% said it helped reduce pain and depression symptoms. So applying technology in lieu of actually pain meds, that's actually incredible. Let's see, Maxwell Health Associates and Hospice Dynamics announced partnership. Both organizations are using predictive analytics, literally to predict death, predict patients' length of stay, predict exacerbations. And then there are a couple of, these are really smart writers, Mark. You probably saw both of these. Healthcare's Oppenheimer moment. That was Becker's. Really good tagline there. This another one. What primary care's Barnes and Noble moment means for the future of digital health. So using some interesting hyperbole in both of those articles. And then there's several articles I just pulled out related to artificial intelligence and how it's being applied to the technology sector. All right, last couple segments. Speed of change and resiliency is another category. And this one I put under here. The number one problem still keeping hospital CEOs up at night. Of course, number one at the list was workforce challenges. This was a Becker article. So workforce challenges, financial challenges, behavioral health and addiction issues, and number 4, access to care. So put that under speed of change, resiliency. My next category is human factor, and there are just a couple that just jumped out at me as a leader, and leadership being my passion. Number 1, the dying art of performance reviews. That was in Becker's. Number 2, mental health service integration in hospice organizations, a national survey of hospice clinicians and medical leadership. And then the one that Mark pointed out, Bristol Hospice's quest to help patients sleep. I just put that under human factor, and I thought that was a great article. And then this one, these 8 traits make great doctors. And by the way, residents can develop these 8 traits. Number 1, are they generous, selfless, humble? Number 2, express values that drive behaviors. Number 3, they're intentional and experts at teaming up with other people, the interdisciplinary team. They're the calm in the eye of the storm. Number 5, they employ a wide array of creative systems thinking to solve problems. Number 6, have exemplary interpersonal and communication skills. Number 7, teach systems-based practice. And then number 8, identify personal and professional mentors as their key to development. And then just last couple, introvert CEOs are poised to thrive. That was a Becker's article talking about introverts are about ready to come into their own. And then this one in Becker's, the most important qualities in a CEO. Number 1, honesty and openness. Number 2, compassion and empathy. Number 3, financial and technical knowledge. And number 4, charisma and public speaking. And then my last category is just articles that almost like my general, I hope you didn't miss. And kudos to Cordt, because Ernesto Lopez at Denver pointed out to him. It was a Harvard Business Review article, Why the Tech Industry Won't Disrupt Healthcare. Really interesting read. I had a couple pearls that got out of that one. And then this one I had 2 minds about. It was in Forbes. End of life. It's the one decision AI cannot predict. And I say I have 2 minds because you got organizations like Hospice Dynamics and Medalogix that are applying predictive analytics. But if you really kind of dissect that article in Forbes, I think what they're talking about is the personal aspect of the decision. Totally agree. You can't put that in machine learning. but there are some interesting ways I think we can apply predictive analytics. And I have a feeling we're going to be talking about that because there are going to be more and more articles throughout this year. 93 articles I cited this month, so that was a lot. And so, all right. Well, appreciate both of you guys. So Mark, do you want to kind of end us on the master class?
Sure, absolutely, Chris. For the masterclass this in communications this month, Chris and Cordt, I thought it might be worthwhile to look at a marketing principle that is often neglected in healthcare. And this, frankly, might be painful for some of your C-suite listeners, Chris, as it concerns the evils, in fact, the sheer destructive nature of acronyms. The top line message, if the name of your hospice is the representation of your brand, then stop denigrating your brand by referring to your hospice by its initials, by its acronym. If the name of your hospice organization is, for example, We Love You Hospice, stop referring to your hospice organization as WLYH. It is not your brand. Hard stop. And most of your external audience, I'm sorry to report to you if you don't know it already, do not automatically think of your hospice brand when they see or hear your name shorthanded into 3 or 4 letters. And this, by the way, is not just about using your acronym externally in a news release or when talking to the media, in a letter to patients and families, volunteers, donors, referral sources, in your newsletter, in a Hospice 101 presentation, or 100 other situations. Absolutely not. It also means stop using the acronym for your hospice when speaking internally to your own staff and your own volunteers. Your nurses, home health aides, social workers, chaplains, and others on your patient care team, we hope, are brand ambassadors. But they likely don't have MBAs in marketing and probably don't fully comprehend the impact of their brand messaging, whether at the bedside, whether talking to referral sources, or when talking to the community. And the same goes for your volunteers. So if you don't want your home health aides referring to your valuable hospice brand by some arcane amalgamation of letters when speaking at the bedside to a patient's 75-year-old caregiver, for example, WLYH will have that new prescription delivered to you. Or if you don't want a hospital discharge planner talking to a family about a referral to something with 3 or 4 letters but no name, for example, we think it's time to consider WLYH, then you simply have to stop using the initials internally. Because using the initials internally implies permission to use it externally. When 2 C-suite executives are heard referring to their employer by their initials, when the CFO sends out an all-staff email that refers to the organization only by its initials, most employees will take that as permission, or actually probably as a best practice command to do so themselves. Using the initials of the organization becomes the secret password to join the inner sanctum of the really cool people in the organization. Just watch when you onboard a new employee, how quickly that new employee starts talking in initials if everybody else is. It's their password to acceptance. Yeah, it's a hassle to spell out the name. And it's also a hassle to spend $500,000 or $1 million every 5 years to refresh your brand because you've frittered away your brand value. Think about it. I know we have a lot of listeners to this podcast who work for or with not-for-profit hospices, so they'll either love this or hate this example. VITAS has grown to be one of the nation's largest hospice providers, in part by rarely messing with its brand. When it rebranded as VITAS Innovative Hospice Care 30 years ago, no one went around referring to VIHC as a convenience. And as serious illness and end-of-life care evolved and VITAS became known as VITAS Healthcare, again, no one goes around referring today to VHC. Similarly, the other of the nation's 2 largest hospice providers, Gentiva, or more formally Gentiva Health Services, while it has undergone far too many ownership changes over the years for anybody to reasonably try to count, it is still known as Gentiva. It's not known as GHS. It's not known as GH for Gentiva Hospice, and it's not known as GHC for Gentiva Hospice Care. Unlike on the hospital side and hospital cost reports and DRGs, there's no allowance for marketing costs in the Medicare hospice benefit. It's an expense an organization, whether for-profit or not-for-profit, has to scratch out on its own through cost efficiencies, savings, productivity enhancements, and for not-for-profits, donor support. That's hard enough to do without the organization itself denigrating its own brand through lazy messaging. So initials, acronyms are not your friend. They are, in fact, your brand enemy.
Well said, Mark. It just was occurring to me. Someone said, I got feedback from someone who goes, I don't agree with everything Mark said. I said, you know what? That's actually why I love having Mark. And where do we evolve to the fact that I only listen to things I agree with? And unfortunately, that is the echo chamber we live today. And so you always make me think. And that's what I love about Cordt and the work that he's doing, as well as providing resources to make us think deeper. I think that was actually solid gold. So thank you, Mark. I was actually going to be a smart button go, thank you, MCNCK, for being here today, which, thank you, Mark. And thank you, Cordt, for being here, because you're both doing amazing work.
Great. Thank you.
All right. So Cordt, I actually asked, so one of the cool things that Cordt did in Hospice and Palliative Care today is at the end is the actual quote. You want to talk about doing the quote at the end, and I'll let you actually close the show with the quote today, Cordt.
Sure. Thanks, Chris. I appreciate that. Interestingly, during the COVID time, I was talking with a hospice CEO in Mississippi, and she just kind of mentioned that she subscribes to this service that gives an inspirational quote every day, and it texts out to all of her staff, and she was commenting on how helpful it was, how inspirational it was. And I thought to myself, there's many things we can do during COVID to try to help. And so I started a Today's Encouragement blog post on my Hospice Analytics webpage. And I started populating it every day with a different blog post, and people, a few, like not many, people subscribed to that blog post. But I just liked the idea of it. And Chris, you close your shows with a quote, and other leaders do as well. So we incorporated Today's Encouragement at the bottom of every newsletter every day. And we try to tune those in. Honestly, during February, for example, there was a conscientious decision to honor Black History Month and use quotes from typically Americans, but Black people around the world in Today's Encouragement. There was a shooting, like we bump into these in hospice, during January, and Joy switched around the Today's Encouragement quote for about 3 or 4 days, just being sensitive to that national event that had occurred. And so we're very purposeful in what we try to do with that. What's been interesting is, while I quoted off the statistics of the most clicked on kind of news categories, the number one category that is clicked on is Today's Encouragement consistently. And Joy and I actually joined by Stephen Gardner, who was the offender at Angola, that you mentioned the article, Death and Redemption in an American Prison. The three of us were at the Georgia Hospice and Palliative Care Organization conference last week, and people came up to me and they said, Cordt, the number one, I read your newsletter every day. The first thing I do is go down to the Today's Encouragement. That's where I start my day. Thank you so much for doing that. So we have been awesome. Looking for those kinds of quotes and inspiration, just a quick gem to help people start their day and continue the great work that our hospice and palliative care professionals are doing. So today I looked through all of the quotes that we used in January, and I would just like to pick one from Martin Luther King Jr., who said, "The time is always right to do what is right." That about sums it up. Thank you for your work, Chris. This is part of doing what's right.
Thank you, Cordt, and thank you for that quote. So to our listeners, thanks for listening to TCN Talks.